Thank you for joining us this morning, this Saturday morning, on your weekends, to listen to this webinar. So, this morning, for this morning's neuro-emergency webinar series, we have two speakers, Dr. Nurul Hafidzah and Dr. Chow Chi Tong. They'll be talking to us mainly about epilepsy. So the first topic is neuro-imaging abnormalities in epilepsy, what to look for, given by Dr. Nurul Hafidzah, followed by the challenges of status epilepticus management in elderly by Dr. Chow Chi Tong. So we'll start with the first topic given by Dr. Nurul Hafidzah, who is a neuro-radiologist from Hospital Putrajaya. She subspecializes in diagnostic neuro-radiology and has done fellowships in sort of quite impressive fellowships actually in multiple places in HKL, National Neuroscience Institute in Singapore. She's got the European diploma by the European Board of Neuroradiology and also a fellowship provided by Johns Hopkins University. So we'll start with her talk first this morning, which is on neuro-imaging abnormalities in epilepsy. So Dr. Nurul Hafidzah, are you ready?
Yes. Thank you to Dr. Diana for the kind introduction. So I'll be off my video.
Okay, so I'll let you share your screen.
Okay, let me share my screen, yeah. Okay, so I hope you can see my screen.
Yep, I can see your screen.
Okay, so first of all, I would like to thank Dr. Nasrina, Dr. Wanshami, and the emergency team for inviting me to be part of this neuro-emergency webinar series. And thank you everyone for attending on your Saturday morning. So I hope it will be beneficial for all of you. So my topic for today is on neuro-imaging abnormalities epilepsy. What to look for. Okay. So I have nothing to disclose for this presentation, and this is the outline of my presentations. Okay. So we're going to see a little bit on anatomy of the temporal lobe and neocortices, the imaging modalities, and also MRI protocol. And lastly, we're going to see what are the causes of epilepsy. Okay, so basically there are several options of imaging modalities pertaining to patients with epilepsy. And it is largely depends on the clinical questions, the indications, and also the onset of seizure. I think for emergency, the more familiar imaging modality for most of you would be CT scan, but actually CT has a limited roles in looking for the structural causes of epilepsy. So MRI would be the better options to look for the structural causes for optimal diagnosis and also for pre-surgical evaluations. So apart from the conventional MRI, we also have a functional imaging, which will be useful to look for the metabolic changes related to epilepsy. So if the first MRI is negative, there's also a role to re-evaluate with another MRI. Usually we will do it within a year to look for any other causes that may be give us the clues for structural causes of epilepsy for that patient. In the patient with non-lesional seizure, bear in mind that it could also be related to a microscopic lesion, and this microscopic lesion may not be visible with the current technology. So when we have all these imaging findings, usually we do not interpret it without correlations with EEG and also clinical simulology. So if you look for the classification by International League Against Epilepsy, so there are different classifications of seizures, different classifications of epilepsies, but to look for the etiology, this is when the imaging would play a role to look for all of this causes, the possible causes. So most of the common causes will be related to structural causes. So it could also be due to genetic, in which you may not have any imaging abnormalities in patients with genetic causes of epilepsy. So in some cases, it could also be related to infectious or autoimmune. And if there is no known causes, which is the cryptogenic, so you may also not get anything on your imaging findings. So out of 30% of all of these epilepsies, the most common causes for both adults and children would be related to temporal lobe epilepsy. And the International League Against Epilepsy has categorized it into two types, which has different clinical and pathophysiological characteristics. So there are mesial temporal lobe epilepsy and lateral temporal lobe epilepsy. So 30% of this patient will develop drug resistance, and 30% will have negative MRI. So just a little bit on the anatomy of the mesial temporal lobe. So when you read the report, the hippocampal formation is normal or hippocampal formation is abnormal. So what we meant by hippocampal formation is this interlocking gray matter folds, okay, which is comprised of the conus ammonis and dentate gyrus. The common conus ammonis has actually 4 parts: CA1, 2, 3, and in the middle is the CA4, and together with CA4 and dentate gyrus is inseparable from imaging. But if you look microscopically, so this is the normal cortex where the gray matter will be outside, white matter will be inside. But for hippocampus, it's a little bit special, where the gray matter is actually inside and the white matter is surrounding it. So this is the white matter at the hippocampal region. We have the fimbria and alveus white matter, and inside it is where the conus ammonis and dentate gyrus is. So on imaging, if you look at the hippocampus on axial plane, it appears as seahorse. Okay? So this is the hippocampus with seahorse appearance. And it can be divided into 3 parts according to its relation to the midbrain. So if it's anterior to the midbrain, we call it head of hippocampus. If it's in line with the midbrain, that's the body of hippocampus. And if it's posterior to the midbrain, that is the tail of the hippocampus. Okay, so usually we will compare it right and left. And then we can also see it on sagittal. Okay, again, divided into 3 according to its position to the midbrain. So we have head, body, and tail of the hippocampus. And anterior to it, we have the amygdala. Amygdala anterior and superior to the hippocampus. Okay, so at the tail, so this is the tail where usually it will have these convolutions, 3 to 5 in numbers of the past hippocampi, only at the tail. And then it's separated from the amygdala by the temporal horn, the ankle recess of the temporal horn of lateral ventricles. And just next to it, surrounding it, this is the parahippocampal gyrus, and it has a collateral sulcus just next to it. Okay, so more medially, we have the brainstem structures. So this is at the head, and at the tail, it's continuous with the a structure, we call it fornix. So it's at the posterior aspect, we call it crus of the fornix. So this crus of fornix will curls around the splenium of corpus callosum and goes anteriorly as the columns of fornix, and it ends anteriorly as the mammillary bodies. Okay, posteriorly, the hippocampal tail also will end as the subsplenial gyri. Okay, another thing that I would like to highlight is the arterial supply of the hippocampus. It is quite special because each part is supplied by different branches. The head of the hippocampus is supplied by P1 of PCA. The body is supplied by P2 of PCA, posterior cerebral artery. And the tail is supplied by the P3 of PCA. Apart from that, head is also supplied by the branch of ICA, which is from the anterior choroidal artery. The body and tail is interconnected by terminal longitudinal segments. So if you have an infarct area at this region, it will have some distinct features, which I will show later. Okay, so when we dealing with patients with epilepsy, Does Tesla matters? Okay, is it important for us to have the best technology to look for the possible findings? Yes, it does. So if you have a higher fields of MRI, you might be able to see the causes better. Okay, so if you compare from the right upper image, this is the 1.5, and then on your left hand upper image, and then the right hand upper image is the 3 Tesla, and at the bottom is the 7 Tesla. So if you look carefully, so the one that can give you distinct anatomical differences will be the 7 Tesla. So where you can see there's difference between the gray matter and white matter, and you can see the convolutions of the hippocampal head better on your 7 Teslas compared to 3 Tesla and 1.5 Tesla. So with higher fields, it will increase the contrast in T2, and it will improve the signal to noise ratio. So you would see the differences between the gray white matter better. Okay, so for MRI protocol, in epilepsy, it is actually important for us to request for the specific epilepsy protocols. It actually different from the stroke protocol versus tumor protocol, because in epilepsy protocol, we usually incorporated this coronal plating card that is put perpendicular to the hippocampal axis. So it will follow the hippocampus. So you would see the internal structure of the hippocampus better. Okay, so there will also be thin slice, 3D T1 ampérage, 2D flare, which can also look for the anatomical pattern, differentiate between the gray white matter. Just like any other sequence, 2D, any other protocol, 2D T2 sequence will be done on axial, but specifically on epilepsy, we have 2D coronal to look for the hippocampal internal structures. And just like stroke protocols, tumor protocols, there's also T2 star magnetic susceptibility sequences to detect minor calcification and hemorrhage, which could also be a part of the causes of epilepsy. So additionally, in all of the epilepsy protocol, you will also include inversion recovery. But if you're in some centers, they can also have the better direct inversion recovery or phase-sensitive inversion recovery, which will delineate the contrast between gray and white matter better. So if you look at this image, so the upper row would be the flare. This is in all other protocols, okay? You will have this flare. But inversion recovery is, usually we will put it on the in epilepsy protocol. So if you compare it between the flare and also inversion recovery, we have the gray, the contrast between gray and white matter better on this double inversion recovery. So you see more hyperintense, subtle hyperintense signals better in this sequences compared to the conventional flare sequence. So if we're suspecting tumor, or if there is any suspicions of infection, we will also include contrast study. So, okay, another things would be the functional MRI, which could also detect metabolic changes related to epilepsy. Perfusion studies can also be added to look for the perfusion changes during epilepsy, during seizure and also post-seizure. There could also be a role for volumetric studies to look for volume loss changes, and MRI spectroscopy to look for metabolic changes related to seizure. Okay, now let's see the structural causes associated with epilepsy. So these are the listed most common causes related to epilepsy. The most common will be hippocampal sclerosis. We also have long-term epilepsy-associated tumor, malformations of cortical development, vascular malformations, including carbonoma, and also scar. Okay, it could be related to old infarct or trauma. So the most common cause will be mesial temporal sclerosis. It can be bilateral in up to 10%, although the patient have unilateral symptomatology. So if we see changes of mesial temporal sclerosis, usually we should look for dual pathology. That means look for any other second epileptogenic lesions, which can present in 15%. So why is it important for us not to be happy just when we have one cause of epileptogenic foci? Because let's say that the patient has mesial temporal sclerosis and also second lesions, the surgical approach will be different. Okay, if there's dual lesions, they might the neurosurgeons might plan for temporal lobectomy rather than just amygdalo-hippocampectomy if it's just a hippocampus sclerosis. So you might also hear some difference in terminology between mesial temporal sclerosis or hippocampus sclerosis. So sometimes it can be interchangeable, especially if it's not. Usually hippocampus sclerosis, we will reserve it when the changes is more at the hippocampus only. But sometimes you may have a very subtle microscopic changes where it also involve outside the hippocampus. It may also involve the adjacent, for example, like parahippocampal gyrus, the amygdala. So usually when we say mesial temporal sclerosis, the areas that we refer to will be a bit larger as compared to hippocampal sclerosis, but it could be interchangeable as well. So in mesial temporal sclerosis, if you look at this image, this is coronal T2. So compare it with the left side, right side. So this right side. So the right side, there is a bright signals within the hippocampal formation, right? So you compare it with the contralateral side. So it's a bit brighter here. And there's also evidence of volume loss. You can see the temporal horn is a little bit prominent compared to the contralateral side. And more anteriorly at the temporal neocortices, we can also see some difference. Okay, so this is the normal side. You see the cortex, the gray matter and white matter. But here you do see the difference between gray and white matter. It's more indistinct and it's a little bit hyper intense compared to the normal side. So this is a changes in mesial temporal sclerosis. So according to the International League Against Epilepsy, histologically, you can categorize it into 3 categories, type 1, type 2, type 3. The most common is type 1, where you see the changes is more generalized, but more severely affected in CA1. Type 2, it's more severely, significantly involved the CA1 only. And type 3, it's involved the CA4 and DG, the dentate gyrus. Okay, so but this is more of histologically. But there's also an entity, we call it gliosis only, no hippocampus sclerosis, in which the ILAE does not classify this as part of HS. Okay, but the astrogliosis itself can play an epileptogenic role. Okay, for imaging finding, when we talk about mesial temporal sclerosis, so the classic findings would be, first look at the abnormal signal change. On T2 or flare, you might see bright signals. Okay, compare with the contralateral side, so bright on the right hippocampus. It could also be volume loss. So if you compare right and left, this is a bit more plump, and this is shrinking. So there is volume loss of the hippocampus. And if it's long-standing, it will also involve the other structures, for example, like the phonics, the mammillary bodies, the entorhinal cortex, and neocortices. And in the cerebella, you might also see a cross-cerebellar dyschisis because of the connections between white matter tract at the cerebropontocerebellar tract. Okay, so you have one side, let's say right side cerebral changes, but the cerebella will be on the contralateral side. Okay, so it could also be bilateral, as I mentioned before, up to 10%. So in this case, you see both sides are a bit bright, but more marked changes on the right side. So it's a bit more flattened compared to the left side. Okay, and in this case, the left side is still in good volume, but it's a little bit bright. The right side is bright and has already flattened. But after 3 years follow-up, both has flattened and shows abnormal bright signal. So this is a case of mesial temporal sclerosis. Okay, if you look into literature, you might come across come across to the amygdala enlargement variant, but this is still debatable because there is heterogeneity in imaging, clinical, and histopathological characteristic. So you might see the amygdala is a bit larger than the contralateral side, but can still be related to underlying FCD, tumor, autoimmune, and it even found in healthy control. So it's still debatable, and there is still more research will be needed, as the current research is usually involving a small sample size with inconsistent study method. Okay, moving on to the next cause of epilepsy is the long-term epilepsy associated tumor. Okay, and the most common one is glioneuronal tumor, which could be related to DNET or ganglioglioma. So DNET is like this embryoloplastic neuroepithelial tumor, and ganglioglioma is also the second common cause for tumor-related epilepsy. So DNET has multiple cystic bubbly-like appearance, and it is rarely a solitary large cyst. So surrounding this large cystic lesions, you may also see a satellite cyst. It can present with enhancement in 30% and 20% would have calcification. Okay, in some cases, you may also see peripheral flare hyperintensity, and most of the NETs are actually WHO grade 1 tumor. Ganglioglioma is another glioneuronal tumor that is associated with epilepsy. So it's usually involved the cortex and subcortical region. It may have enhancing mural nodule. So within the cystic lesion, you see enhancing solid component. We call it enhancing mural nodule in 40% of the patient. And you may also see calcification in 30%. So ganglioglioma is also WHO grade 1 in 95%, but 5% is grade 3. Next is glioma. So glioma is also another tumor that may cause epilepsy. So it could be a low-grade glioma, for example, like in this case, where on the left side, you compare it with the right side, this is very swollen, very bright, and it does not show any enhancement. So this is grade 2 astrocytoma, whereas grade 3 astrocytoma may shows a little bit of restricted diffusions on DWI with minimal enhancement. Other tumor that may also be associated with epilepsy is like multinodular vacuolating neuronal tumor, where you see small cysts more at the subcortical regions. And you can also see this polymorphous low-grade neuroepithelial tumor of the young, its short form is PLNTY, where there is classic central calcifications and peripheral located cysts. Other tumors that may also be associated with epilepsy is like pilocytic astrocytoma, pleomorphic astrocytoma, as well as angiocentric glioma. Okay, moving on to the other causes of epilepsy is malformations of cortical development. It is usually related to disruptions of the normal process of cortical development. So in development of the cortex, there's 3 sequential steps. The first one will be neuronal and glial proliferation. Second one, neuronal migration. And the third will be the cortical organization. So if any disruptions to this process, it will lead to one of these malformations of cortical development. So the most common one is focal cortical dysplasia. Histologically, there is actually different type in FCD. Type 1, where it's only involved the abnormal cortical lamination. Type 2, when there is these laminations, either with balloon cells or without balloon cells. If it's with balloon cells, we call it 2B. If without, it's 2E. And type 3, when the FCD presented with other pathologies such as hippocampus sclerosis, tumor, vascular malformations, and other things like trauma, ischemia, or encephalitis. So in FCD, the point that we need to look for is whether there is blurring of gray-white matter differentiations. And we can also see a transmental sign where there is connecting hyperintensity from the ventricle wall to the cortical abnormalities. Okay, so this is in FCD type 2. Sometimes the changes is very subtle, might be missed, especially when it's involved only at the bottom sulcus, okay, at the inferior aspect of the sulcus. So if you look at here, there is just subtle hyperintense signals with loss of gray-white matter differentiation. And this is what we call bottom sulcus FCD. Okay, another type of malformations of cortical development is the hemimegalencephaly. So in hemimegalencephaly, we have asymmetric growth of the cerebral hemispheres. And and on top of that, we might also have some ventriculomegaly on the site where it is affected. There could also be some signal abnormalities. And this abnormal enlargements of the hemicerebral would cause lateralizations of the falx cerebri. So if you see one side is a little bit bigger, so think of hemimegalencephaly. Another thing is gray matter heterotopia, where you might see some abnormal locations of the gray matter. Normal locations of the gray matter. So if it's periventricular heterotopia, so you would see this abnormal gray matter along the ventricles. So it could be unilateral, it could be bilateral, it could be single, it could be multiple, and it could also be contiguous heterotopia. So apart from periventricular heterotopia, there is also subcortical heterotopia, where the gray matter is noted abnormally within the subcortical regions. And there's also a terminology called band heterotopia, where there's some ribbon-like subcortical gray matter. And this abnormal gray matter is separated from the cortex by a thin layer of the white matter. Okay, so when you say heterotopia, it could be periventricular, it could be subcortical, or it could be a band heterotopia. Okay, next is polymicrogyria. So polymicrogyria is basically abnormal excessive numbers of small gyres. Okay, it could be seen along the perisylvian region and commonly also at the parasagittal parietal occipital. So if you look at this image, at the top image, there is, okay, compare with the normal salsa and gyrus, normal gyrus, you see gray and white matter. But this one, the cortex is a bit thickened and you don't see the distinction between gray and white matter. Okay, so if you look on T1, this is T1 sagittal, compare it between anterior and posterior, there is some abnormal gyrations, okay, a little bit more kat sini a bit more rapat-rapat, okay, and then a bit more thicker cortex. Okay, so this is polymicrogyria. So if you look at the bottom image, there is polymicrogyria as well. Look at the perisylvian region, it's a bit more busy here. So you see thickened and shallow cortex compared to the normal one. Okay, if you look on sagittal, again you see this polymicrogyria along the Sylvian fissures. Okay, next is schizencephaly. So schizencephaly is basically CSF field cleft outlined by the gray matter. Okay, or polymicrogyria. So this is outlined by gray matter, abnormal gray matter. So this cleft will be seen from the ependyma sending to the pia. So if it's go all the way, we call it open schizencephaly. If it's disrupted halfway, we call it closed-lip schizencephaly. Okay, so when you see defect, okay, outlined by the gray matter, think of this schizencephaly. Okay, next cause is vascular malformation. So it could be arteriovenous malformations. So in arteriovenous malformation, you will see a nidus, very entangled vessels with enlarged draining vein and feeder arteries. So this is AVM. Whereas cavernoma, it's a cavernous angioma. So you don't have a dilated draining vein, but you see a popcorn appearance, okay, with susceptibility on T2 star or SWE images. And on T2, you would see hyperintense in the middle and hypointense hemosiderin rim at the peripheral. Okay, and the other cause that should be think of when you have a patient with epilepsy, especially if in older patient, thinks of whether it's related to scar, previous injury, could be due to chronic infarct. This is actually quite common, especially in older age patients. So if the patient has epilepsy, try to look for if there is any old infarct. Okay, so it could also be related to chronic hemorrhage. Okay, so chronic hemorrhage might be a little bit difficult to be seen on CT, but on MRI, SWE, you might see some hemosiderin depositions, okay, indicating a chronic hemorrhage. Okay, so after you try to look for all the structural causes, think of a possible differential diagnosis for that may also cause epilepsy. So it could be related to anatomic variants, could be associated with autoimmune encephalitis, could be due to underlying infections. It could also be because of toxic metabolic, or it could also be due to defect in encephalocele, or the patient may also have acute infarct, or in older patient, it could be transient global amnesia. And you may also see some findings which is actually related to postnatal changes. So for anatomic variant, the mesiotemporal structures, it is formed by the primitive allocortex. When we say primitive allocortex, means the cortex has only 3 up to 5 layers. It does not have a complete 6 layers. Whereas if it's neocortex, it has complete 6 layers. So it's a bit special. And this mesiotemporal allocortex development, it's usually start with a flat cortical plate, and with time, it will gradually unfold and give us the hippocampal formation. Okay, so when failure of this hippocampal folding, you would have this abnormal round hippocampal shape. So if you compare it with the normal side, on the right, the left is a bit more round, a bit more bulat. Okay, you might also have vertical quadrilateral sulcus. The temporal horn may also be prominent, and the phonics would also be a bit lower. Okay, but if you compare on the signal intensity, it may shows no abnormal hyperintensity of the hippocampus itself, but the orientations, the appearance, and the surrounding may show some asymmetrical. So this is a case of incomplete hippocampal inversion. Another anatomical variant would be of the sulcal remnant cyst. So it depends on the positions of the cyst. So if it's within the hippocampal itself, we call it hippocampal fissural cyst. If it's along the thoracic fissure, say it's choroidal fissural cyst. So this could also be your differential diagnosis. So when you see this kind of lesion, is not always tumor. It could also be due to anatomic variant. Now the thing is arachnoid cyst, so it may appear as excessive signal intensity in all sequence, and epidermoid cyst, where you would see restricted diffusions on DWI ADC. Okay, so you might also come across this kind of findings when you're evaluating for patients with epilepsy. Next is autoimmune encephalitis. So clinically, the patient may be presented with subacute onsets of seizure, confusion, memory loss, and also psychiatric symptoms. Whereas in imaging findings, especially on MRI, you might be able to see some abnormal signals and swelling of the limbic structures. Okay, but on the earlier images, it will be more of swelling, more of inflammatory changes. But with time, it will show progressive atrophy. So when we're dealing with patients suspected of autoimmune encephalitis, it is also important for us to further investigate the patient for paraneoplastic and non-paraneoplastic causes. Next is infections. So sometimes it can be difficult to differentiate it with autoimmune encephalitis because both may also involve the limbic areas. But usually herpes encephalitis will spare the basal ganglia, whereas autoimmune may tend to involve the basal ganglia as well. And herpes tends to have more restricted diffusions, more hemorrhagic changes, and it can also have mild enhancement. The other infection that can also be associated with seizures is things like neurocysticercosis, where you might be able to see the eccentric enhancements, we call it scolex, usually appears during vesicular and colloidal phase. And rim enhancing lesions, which is more common in Malaysia, is also tuberculoma. So especially when you see it at basal cisterns, so think of tuberculoma. Metabolic causes that may be associated with seizures is things like hypoglycemia or kernicterus. It may appear similar. Thus, it is important for us to correlate it with clinical. And in this case, where you see abnormal signals specifically at the globus pallidus, so think of carbon monoxide poisoning. Okay, next is infarct, which is also a common finding in our daily cases. So for infarct, usually it is uncommon for us to have only hippocampus infarct. Most of the time, we will have some extra hippocampal infarct as well because of the arterial distributions, right? So if you look at this upper row image, so the patient has some bright signals within the hippocampus. Okay, if you compare it with the normal side, so this is a bit more brighter. On ADC, we have very low, but not only at the hippocampus, you also see it at the occipital. Okay, so all of these are a supply of the PCA territories. And when you look at the MRA, compare it with the contralateral side, the MRA on the right side, at the PCA on the right side, shows no signal flow as compared to the contralateral side. So this is a PCA territory infarct with infarction at the right occipital and the right hippocampal, probably right hippocampal body. Okay, whereas at the bottom row image, you see this is the hyperintense signals on DWI at the posterior limb of internal capsules. So if you learn the anatomy, posterior limb of internal capsule is supplied by the anterior choroidal artery. So anterior choroidal artery also supply the head of the hippocampus. So you see similar changes on both head of hippocampus and the posterior limb of internal capsules. So if you correlate it with anatomical supply of the arteries, it's consistent with anterior choroidal artery infarct. Okay, in the patients, especially older than 60 years of age, patient presented with sudden onset syndrome, which lasts less than 24 hours. The patient presented with antegrade and partial retrograde memory loss. There is also a role for MRI where you can see some punctate, punctate restricted diffusion foci within the hippocampus. So if clinically it correlates and then the MRI is also shows this focal changes, you may diagnose the patient as transient focal amnesia. So the diagnosis is mainly clinical, but the hypothesis of etiology has been made probably related to arterial thromboembolism, venous congestions, could also be related to epilepsy and migraine. Okay, and I think the last one is post-ictal changes. Sometimes it can be difficult even for us to differentiate whether this is a solely post-ictal or is it post-ictal with associated changes, for example, like post-ictal plus coexisting infection. Sometimes it can be difficult to delineate which is which. Okay, so but post-ictal changes is usually it will show resolutions within days and it can persist up to 30 days. Okay, so if you do imaging very fast, it may show some perfusions changes. Okay, especially during ictal phase, you might see hyperperfusion due to vasodilatations. And immediately after the seizures settles, it may shows evidence of hyperperfusions, hypo. So initially vasodilated and then it shows hypoperfusion. So initially hyper and then followed by hyperperfusions. So the first changes that can pick up is through perfusion studies. Within hours, you might see some changes on DWI and ADC, in which due to the cytotoxic edema, you might see bright signal on DWI and low signals on ADC. So T2 and flare will show later changes where you can pick up hyperintense signals on both T2 and flare. And these changes, usually if it's only because of post-ictal, it will not stay up to 30 days. So within days, up to 1 month, it's supposed to show some resolution. So for post-ictal changes, if you compare with infarct, so usually infarct, it will follow the arterial territories, right? So it's not supposed to, let's say this is MCE territory infarct, it shouldn't involve the mesial frontal. It shouldn't involve the parietal occipital. But if it's post-ictal, it will not follow the arterial territories. So the changes that you see here is more of hemicerebral and more of cortices. And sometimes you may also see cross-cerebellar disguises. Okay, and the lower part, the lower image, okay, what you can see here is more symmetrical at the putamen and at the mid-temporal lobe. But with time, after 6 days, these changes has started to show some resolutions. Okay, so this is more of post-ictal changes. Okay, so basically, my take-home message is neuroimaging is important because we want to look for the possible diagnosis. And some of this diagnosis is surgically correctable. Some are treatable. And some can be because of anatomic variants. But sometimes the MRI may not have a characteristic feature, or it may have an overlapping features. Thus, it is also important for us to correlate it with clinical history and think of other differential diagnoses that could also be part of the epilepsy causes, for example, like vascular causes, inflammatory causes, and infectious causes. All right, so with that, thank you. Is there any question?
Thank you very much for the talk. It looks, it was very interesting. Thank you. I mean, I
hope
enjoyed
it's
it
not
very
too
much.
heavy for Saturday morning.
No, it was very good wake up call. I think. Anyway, anyone has any questions for the presenter? Anyone, any questions? I was just wondering, like, from myself, for especially bilateral mesial temporal lobe epilepsy, for the changes, usually, like you said, compare left and right. But for bilateral, which sequence would be best to detect the hyperintensity? Because I think that would probably be the main problem
Flare
in
is
clinical
usually more
setting.
sensitive, but I will usually correlate with T2 as well, because sometimes flare tends to have artifacts as well, right? So usually I will not stop at flare. I will look at the flare, T2, and I will also place with the inversion recovery and T1 to look for any abnormal changes, because it's usually we look for the loss of internal architectural structures, right? So apart from only for bright signal, also look for the gray-white matter loss. So these 4 sequences, for me, it's important for you to review before you make a conclusion that whether this patient has mesial temporal sclerosis or not.
Oh, so when you say you compare flare and T2, it's to rule out the T2 shine through, is it?
Bukan, to look for whether this is, sometimes if you just rely solely on flare, you're not so sure whether it's just artifactual or is it a real bright signal, okay? So usually I'll take flare and then I look at the T2 as well. And if to convince myself, I will also look at the T1 and also inversion recovery. look at the gray and white matter. Is it lost or is it perfectly normal?
Mhm.
Uh,
Oh, okay. So to see whether there's corresponding changes in all the sequence juga.
So you cannot rely just bright signal only. So you have to look for the internal structures as well.
So for like congenital anomalies like the FCD and polymicrogyria also you use the same sequences.
Mm.
I think that one. Oh, okay.
It's just that for FPD, it's
Hmm?
bright, but the cortex usually will also be thicker with indistinct margin.
Yeah, because they're quite subtle changes, right? So I
Mm.
think would I'm guessing whenever we request for a epilepsy protocol MRI, probably it would be helpful for you guys to have the EEG results as well.
Yes, yes. Actually, it is
Um,
very helpful. It may be biased, but
mm,
sometimes it can be difficult for us to make a conclusion without EEG as well, can? So usually, if we have the EEG findings beforehand, I think it will be helpful for us to make the conclusion lah.
okay, yeah. Because I think most of the time we request the MRI before we do the EEG.
Tapi there is actually a roles of the functional studies, for example, like the perfusion studies,
Mm,
where you can also look for hypometabolic changes kan. So the same thing like you pakai PET and SPECT CT. So
mm-hmm.
in perfusion studies, you look for evidence of hypoperfusion. You compare it with the rest of the brain. If let's say you have suspicions at the, let's say, right temporal, kan, then you look
Mm.
at the functional studies, at the perfusion studies, that there is also evidence of hypoperfusion at that region. Then you are more confident to call it maybe the epileptogenic foci is there, something like that. Yeah.
Oh, okay.
Mm.
No, hyperperfusion also can help.
Yes.
When you say hippocampus axis, can you clarify? Is the coronal axis of the hippocampus?
When we want to make it coronal view, so we will follow the we will put the axis longitudinal axis to the hippocampus. That means when you, okay, let's say you have a 3D, right? 3D image,
Mm.
you will align it according to the sagittal view, on the sagittal view, according to the hippocampal axis.
Or to the folding of the hippocampus that you
Yes.
showed in the presentation.
Yeah. If you
Okay.
remember my sagittal view image,
Mm.
we can see head, body, and tail
Yes.
and sagittal, right? So
Mm.
usually we will align it according to that hippocampal axis. Then you get a
Okay. So
coronal, good
perpendicular to
coronal.
that. Okay.
Mm.
Okay, makes sense. I think that's all from me. Anyone else got any question? I also would like to say the status epilepticus changes. I find that interesting.
The
Not
changes.
actually thought about it before. Yeah.
It actually depends on when do you send the patient for MRI lah.
Hmm.
Uh,
Okay. Um. Anyone else has any questions? If not, thank you very much, Dr. Nurul Hafidzah. I enjoyed that talk very much. So we can
Thank
actually
you.
move on to the next presenter, Dr. Chow.